Hello, my name is Julia Lee, and this is my head-to-toe assessment for NURS 7646, Section M53 for Spring 2025. I will start off by scanning the room. This is my equipments, the floor, and the ceiling. Alright. I will start off by saying that throughout the assessment, I will be checking the skin of the head, neck, face, the anterior chest, posterior chest, abdomen, upper extremities, and lower extremities for color, temperature, texture, turgor, moisture, scarring, bruising, lesions, nevi, or edema. I will start off by inspecting the head. Upon inspection, the head is normal cephalic, midline in position, and symmetric. Now I am going to inspect and palpate the scalp. Hair is distributed evenly, smooth in texture, black in color. There are no evidence of any masses, tenderness, lesions, infestations, or depressions. Now I'm going to palpate the temporal artery. No tenderness noted. Now I'm going to palpate the lymph nodes of the head and the neck. Preauricular, postauricular, occipital, tonsillar, submandibular, submental, anterior cervical, posterior cervical, and supraclavicular. Now I'm going to move on to checking for assessing cranial nerve number 5, trigmenal, by having the patient clench her jaw while I palpate the masseter muscle. Now I'm going to have the patient close her eyes and let me know where on her face I am touching. Forehead,
nose, chin, cheek.
Cranial nerve number 5 is intact. I'm going to also check palpate the TMJ by having the patient open and close her jaw. All right. No subluxation, crepitus, or tenderness noted. Now I'm going to move on to check cranial nerve number 7, facial, by having the patient smile, frown, raise eyebrows, puff her cheeks, and pucker her lips. All right. Facial expressions were symmetric. Cranial nerve number 7, facial, is intact. Now I'm going to move on to the ears. Upon inspection of the outer ear is midline in position, symmetric, colors appropriate to ethnicity. There are no obvious breaks in skin integrity. Now I'm going to palpate the pinnae and tragus. No tenderness noted. Now I'm going to use my otoscope to inspect the auditory canal and the tympanic membrane. Okay. Auditory canal is clear bilaterally and tympanic membrane is pearly gray in color bilaterally. Now I'm going to test cranial nerve number 8, vestibulocochlear, by performing 3 different tests. I will start off with the whisper test by having the patient occlude one ear and repeat after me.
1, 2, 3.
The other side.
1, 2, 3.
All right. Now I'm going to use the tuning fork to perform the Weber test to test for lateralization. I will have the patient let me know if she can hear the sound better in the middle or on one side more than the other.
Middle.
All right. Now I'm going to also use the tuning fork to perform the Rene test by having the patient let me know when she stops hearing the sound.
Yeah.
And the other side. Air conduction is greater than bone conduction. Cranial nerve number 8, vestibulocochlear, is intact. Now I'm going to move on to the eyes. I'm going to inspect the eyes, the lashes, brows, palpable fissures, sclera, and conjunctiva. Upon inspection of the eyes, they are equally distanced. The lashes and brows are full in thickness and hair distributed evenly. Now I'm going to check the sclera and conjunctiva. Sclera is white, conjunctiva is clear, there are no lesions or discharges. Now I'm going to move on to test cranial nerve number 2, optic by having the patient cover one eye and read the lowest line possible on the Snellen chart.
FPH. LTFFH.
Alright, the patient has 20/20 vision and 20/30 on the other side. Now, cranial nerve number 2 is intact. Now I'm going to test cranial nerve number now I'm going also to test cranial nerve number 2 peripheral vision by having the patient cover one eye and let me know, look straight ahead and let me know what number I'm holding.
2, 2, 2, 3, 2.
Alright, and the other side.
2, 3, 2, 2.
Alright, cranial nerve number 2 is intact. Now I'm going to move on to cranial nerve number 3, optic. By having the patient look straight ahead, I'm going to check the pupillary responses to light. Okay, and follow this. Okay, pupils equal, round and reactive to light and accommodation. Cranial nerve number 3 is intact. Now I'm going to move on to test cranial nerve number 3, ocular motor, cranial nerve number 4, trochlear, and cranial nerve number 6, abducens by having the patient follow my finger. Okay. Cranial nerve number 3, 4, and 6 are intact. Now I'm going to use the ophthalmoscope to inspect the red reflex and the internal eye structure. Alright. Red reflex intact and sharp disc margins bilaterally. Now I'm going to move on to the nose. Upon inspection, the nose is midline and straight. There are no break in skin integrity. Color is appropriate to ethnicity. Now I'm going to test cranial nerve number 1, olfactory, by having the patient close her eyes and let me know what she smells.
Coffee.
Okay. Cranial nerve number 1 is intact. I'm going to have the patient occlude one nostril and blow out, and the other side. Nasal patency is intact, and now I'm going to palpate the frontal and maxillary sinuses. Now I'm going to move on to inspecting the lips, the teeth, the gum, buccal mucosa, palate, tongue, under the tongue, salivary ducts, posterior pharynx, and the tonsils. Okay. And I would be grading the tonsils if they were present. Now I'm going to move on to testing cranial nerve number 9, glossopharyngeal, and cranial nerve number 10, vagus, by having the patient stick her tongue out and say ah. Soft palate and uvula rise with phonation symmetrically. Now I'm going to test for cranial nerve number 12, hypoglossal, by having the patient stick her tongue out and move it side to side. Okay, tongue midline without fasciculations. Now I'm going to move on to the neck. Upon inspection, the neck is midline in position. Color is appropriate to ethnicity. There are no swelling noted. Now I'm going to palpate the thyroid, or the trachea, I'm sorry. Okay, trachea is midline. Now I'm going to palpate the thyroid. Swallow for me. Alright, and then now I'm going to palpate the carotid artery one at a time. 2+. And now I'm going to listen to the carotid arteries for any bruits. Hold your breath. Okay. Hold your breath. Alright. No bruits noted. Now I'm going to have the patient go ahead and check her range of motion for her neck as well while we're already here. I'm going to have the patient flex, look down, extend in the middle, hyperextend on back, lateral flexion side to side, and then rotation. Okay. Full range of motion in the neck. I'm going to also check cranial nerve number 11, accessory muscles, by having the patient shrug against resistance. Alright. Cranial nerve number 11, accessory muscles are intact. Now I'm going to move on to the posterior chest while having the patient turn around for me. I'm going to check for signs and symptoms of respiratory distress, such as use of accessory muscles, nasal flaring, tripod positioning, tachypnea, retractions, or cyanosis. I'm going to also check for any obvious deformities and symmetry. Now I'm going to check for chest rise expansion by having the patient breathe in and out. All right, and then tactile affirmatives by having the patient say 99.
99, 99, 99.
All right, and now I'm going to percuss the lung fields. All right, and now I'm going to palpate for CVA tenderness. Let me know if this hurts.
Nope. Nope.
All right, that's good. And now I'm going to auscultate the lung fields by having the patient take some deep breaths for me. Clear breath sounds heard in all lung fields. Now I'm going to test for egophony by having the patient say E every time I listen.
E, 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 E.
All right, now I'm going to test for bronchophony by having the patient say 99.
99, 99, 99, 99, 99, 99.
All right, now I'm going to check for whisper pictoriloquy by having the patient whisper 99. Okay, now I'm going to have the patient turn back to the front. I'm going to check the anterior chest, and during this time I'm also looking for signs and symptoms of respiratory distress or any obvious deformities in symmetry. Now I'm going to check for chest rise expansion by having the patient breathe in and out. All right, and tactile firmness by having the patient say 99.
99, 99, 99, 99.
Okay, now I'm going to listen again, auscultate the anterior chest in all lung fields. Clear breath sounds heard in all lung fields. Now I'm going to move on to the heart. I'm going to listen to the heart with my bell and my diaphragm, starting with the diaphragm first. We're going to do aortic, second right intercostal space, pulmonic, left second intercostal space, Erb's point, third left intercostal space, tricuspid, fourth left intercostal space, and mitral, fifth left intercostal space at the midclavicular line. And with my bell, aortic, pulmonic, Erb's point, tricuspid, mitral. S1, S2 heard, no extra heart sounds or murmurs. Now I'm going to identify and palpate the PMI, which is at the fifth intercostal space, the midclavicular line. Now I'm going to listen to the apical pulse for 1 full minute. Regular rhythm, rate is 78. Now I'm going to have the patient lie down. And have the patient lift her head up about 30 to 40 degrees. All right, I'm gonna come over here. There are no JVDs or jugular pulsations noted. There are no lifts and heaves noted as well. Now I'm going to palpate the 5 points for any thrills. Aortic, pulmonic, Erb's point, tricuspid, mitral. No thrills. Now I'm going to listen again to both the diaphragm and the bell to all 5 points. Aortic, pulmonic, Erb's point, tricuspid, mitral. Aortic, pulmonic, tricuspid, or Erb's point, tricuspid, mitral. Right. S1, S2 heard, no extra heart sounds or murmurs. Now I'm going to move on to the abdomen. Upon inspection, the abdomen is flat and contoured and symmetric. If the patient was undressed, I would also be checking the skin. Now I'm going to auscultate over the arteries, aorta, renal, iliac, femoral. Right. Now I'm going to listen to our 4 quadrants for bowel sounds. Right lower quadrant, right upper quadrant, left upper quadrant, left lower quadrant. Okay. Normal active bowel sounds heard in all 4 quadrants. Now I'm going to percuss for any tympany, dullness, or flatness. Okay. Now I'm going to palpate the 4 quadrants for any masses or tenderness, light palpation first, and then deep palpation. No masses or tenderness noted. Now I'm going to try to palpate for the liver and the spleen. They are non-palpable. Now I'm going to have the patient sit up, and we are going to move to the upper extremities. I'm going to check the joints of the fingers, hands, wrists, elbows, and shoulders. Checking for any redness, swelling, tenderness, deformities, crepitus, or nodules. None are noted, no edema is noted, colors appropriate to ethnicity, they are symmetric and warm to touch. Now I'm going to move on to the fingers. So what we'll do is now I'm going to check the capillary refills of the fingers. All right, less than 2 seconds, and the radial pulses, 2+. Now we're going to do range of motion of the fingers. So we're going to flex, extend, hyperextend, abduction, adduction, thumb up position. All right, now check the strength of your fingers. So go ahead and squeeze my fingers. All right, full range of motion in the fingers and 5 out of 5 strength in the hands. Now we're going to move on to the wrist. So we're going to flex, extend, hyperextend, ulnar deviation, radial deviation, ulnar deviation, rotation. Full range of motion in the wrists. Now we're going to do the elbows. We're going to flex, extend, hyperextend. All right, full range of motion in the elbows. Now I'm going to check the strength of the triceps and biceps. Have you go like this for me. Pull or push, and then push. All right. Full range of motion in the elbows and full strength in the triceps and biceps. Now we're going to do the shoulders. We're going to flex, extend, hyperextend, external rotation, internal rotation, adduction, abduction, and then circumduction and circle. All right. And then now we're going to do the full range, or the strength. I'm going to have you pull your hands out to the side, push in for me, and then push out. All right. Full range of motion and 5 out of 5 strength for the shoulders. Now I'm going to move on to light touch sensation for the upper extremities by having the patient close her eyes and let me know where I'm touching.
Hand.
All right. Now I'm going to check vibratory sensation by having the patient let me know if she can feel this.
Yes.
All right. Now I'm going to check for cerebral, or assess the cerebral coordination by having the patient touch each finger to her hands. All right. And then hand flip-flop, and then your finger to my finger. And the other side. You gotta go back.
Oh.
Yeah, okay. All right. Cerebral coordination is intact. Now I'm going to check the deep tendon reflexes of the brachioradialis, the triceps, and the biceps. So, triangle, yep. And this side. come over here. Alright, now the patellar, the Achilles, and Babinski's. Alright. Now I'm going to move on to assessing stereognosis by having the patient close her eyes and open her palms and let me know what she's holding.
Cotton ball. Cotton ball.
Okay. Stereognosis is intact, and now I'm going to assess graphesthesia by having the patient close her eyes again, open her hands, and let me know what I'm writing on her palm.
O. O.
Right. So graphesthesia is intact. Now I'm going to move on to the lower extremities. So I'm assessing the toes, the ankles, the knee, and the hips. Alright. Checking the joints for any redness, swelling, deformities, tenderness, nodules, or crepitus. And none are noted, no edema present. Extremities are warm to touch, colors appropriate in ethnicity. I'm going to check capillary refills. Less than 3 seconds. The dorsalis pedis pulses and the posterior tibial pulses. 2+ pulses for both. And then now we're going to do range of motion for the toes. We're going to have the patient flex, extend, hyperextend, abduction, adduction. Okay. And the full range of motion in the toes. Now the range of motion in the ankles. We're going to flex, or dorsiflex, plantar flex, inversion, eversion, and then rotation. Full range of motion in the ankles. Now I'm going to test the strength in the ankles by having the patient push down like a gas pedal and then push up to the ceiling. All right. 5 out of 5 strength in the ankles. Now for the knees, we're going to do full range of motion, push up and then push back. Full range of motion in the knees. Now in the hips, push in and push out. Full range of motion in the knees. Now I'm going to have the patient stand up. And we're going to do range of motion in the knees first. So we're going to flex, extend, hyperextend, and the same side, flex, extend, hyperextend, sorry, yes. And then full range of motion in the knees. Now in the hips, we're going to flex, extend, hyperextend, inversion, eversion, adduction, abduction, circumduction. All right, same side. Flex, extend, hyperextend, inversion, eversion, adduction, abduction, circumduction. All right, full range of motion in the hips. Now I'm going to have the patient turn so I can inspect the spine. So upon inspection of the spine, I'm checking for expected curvature, any tenderness, and alignment. Now I'm going to have the patient bend at the hips. I'm checking for any signs of scoliosis. There are none. Now we're going to do full range of motion. Or now we're going to do the range of motion in the spine. So stand up for me and then lean back. Hyperextension. Okay. Now lateral flexion side to side. And then rotation, turn. Okay. Full range of motion in the spine. Now I'm going to assess for Rumberg. So have the patient facing the camera. Close your eyes. Put your hands out. Okay. Now we're going to check gait. So I have you walk. I guess you can walk towards me. Okay, and then walk back heel to toe. All right, normal gait, and then hop on one foot, and then the other side. And that concludes my head to toe assessment.